Kia ora koutou, he mihi mahana. He mihi arawa kia koutou, nā kai mahi hauora I whakanui I tēnei hui. Nō reira, tēnā koutou. Yes, my name's Peter Jansen. I work as clinical lead treatment injury. Here's what I'm going to talk about. Something about treatment injury cover. I'll talk a little bit about ACC cover as well, all the way down to professional accountability. So let's talk a little bit about ACC. You all know ACC, apart from Michael, and he gets to learn something new every day. Wonder what today it'll be. But we all know ACC, don't we? We provide cover for all New Zealand residents and anybody in New Zealand for personal injury caused by accident. So we have different types of cover. We have the normal, what we in ACC called PICBA, P-I-C-B-A, PICBA, personal injury caused by accident. That's like falling off your mountain bike, getting run over by a car. That's the bulk of the nearly 2 million claims a year made to ACC. Then there are some smaller parts. Work-related gradual process disease or infection. It's a really tiny part of ACC. Almost all of those are declined because it's a really high barrier to getting a claim for work-related gradual process disease or infection over the line. Medical treatment, treatment injury, that's around about 18,000 claims a year. Nearly 40% are declined. Once again, there are thresholds. We'll talk about more about that later. And then there's also sensitive claims. That's mental injury caused by something in the nature of a sex crime. You can also have cover for mental injury because of your physical injury, mental injury because of the Criminal Act, the sensitive claims, and since 2005, mental injury caused by witnessing in close physical proximity a traumatic workplace event. Let's not go there, it's really hard to describe that. Before we go further, sometimes physical injury can involve inhalation of here's today's lesson, Michael. Inhalation of a substance on a specific occasion, ingestion of a substance on a specific occasion, or absorption of a chemical through the skin for a time period not exceeding 1 month. Because I've got a note here. It says, would the woman who used the deep heat get cover with ACC? What does this table think? Why? Why? Which of these categories is it? Who prescribed the deep heat? The pharmacist should have warned her. So that's a failure to treat, failure to properly diagnose and warn. I'm going to ask a different table. I'm going to ask this table, what do you think? Does the woman who used deep heat get cover with ACC, and under what category? No. No cover? No, this is about deep heat, not cutting yourself. Oh, let's go to the next slide, and then we'll come back and ask you again. So talking about treatment injury, this is a personal injury caused by treatment provided by a registered health professional. First point is not all registered health professionals are included in this part of the Act. Only the health professionals listed in Section 6 of our Act. So some health professionals are out, for example, osteopaths. Pharmacists are in, doctors are in, nurses are in, chiropractics are in, dentists are in, podiatrists, you'll have to go and look that up. So it has to be treatment provided by a registered health professional as per Section 6. Now there's a whole lot of exclusions. The injury cannot be a necessary part of treatment. The example I'll give is if I clutch my right lower quadrant, double over and get a fever, you will think maybe he's got appendicitis and take me to hospital. Somebody will make an incision, likely to remove my inflamed appendix. Either a small incision and put a laparoscope in, or a big incision because it's all festering in there, and take out all the stuff that's festering. The incision is necessary. I don't have cover for the necessary incision. Also, I will not have cover for the ordinary consequences of treatment. That's difficult, isn't it? What is an ordinary consequence? Don't answer that. Because there is no more explanation in the Act, the legislators only gave us those words, not an ordinary consequence taking account of the circumstances, including the underlying health conditions, etc. The courts are really struggling with that. Also, you can't have cover if you've withheld consent. If my health professional gives me clear instructions about what to do and I ignore those, that's not a treatment injury. That's me ignoring the very careful instructions of my registered health professional. Can't be due to the underlying health conditions, so that's things like diabetes causing peripheral vascular disease. The only basis of the claim is that you didn't achieve the desired results, you're excluded, and attributable to a resource allocation decision. That last one we do have case law on. It involved transferring a patient by helicopter from Taumarunui to Waikato Hospital at a time when the weather was really bad. There was a lot of fog. Who knew there'd be fog in Hamilton? Oh, I did. I was born there, as you know, Michael. Fog. That's a great thing. It means there's no wind. Anyway, because the helicopter couldn't fly and the road was out and the weather was against it, the person's health condition got worse. They got a personal injury caused by the delays, but the judge says you're excluded because that was resource allocation. So we decline claims in treatment injury. About 35% of claims from DHBs are declined. It's a lesser percentage in private hospitals. It's a much higher percentage from primary care, closer to 50%. That's really intriguing to me. It means that people don't understand the basis of making a claim. I'm not blaming you, I'm blaming ACC. We need to explain that much better. When we look at those declined claims, nearly 2/3, there's no physical injury. And that's kind of tricky. That sounds really simple on the face of it, but remember that the courts have said a physical injury is actual bodily harm. Microscopic injury is excluded. Raised liver function tests are not the basis of making a claim. You need more. Somebody with raised liver function tests and they're yellow, that looks like your liver's damaged and there's actual bodily damage versus just a little raise in your GGT. Probably not an injury, Michael. It's probably just too much wine I had. About 20% of our declines, the treatment was not provided by a registered health professional, and the ordinary consequences of treatment are just over 10%. Here's the issue that's facing us. Since treatment injury came in 2005, there's been a rapid increase in the number of claims and the cost of those claims. You've got two lines here, the red one, which is all treatment injury claims, and the dotted blue line, which is what we call entitlement claims. Entitlement claims is people who needed more than just initial treatment. So they may have needed earnings-related compensation, they may have needed more surgery, they may have needed attendant care and home help and house modifications and all those things that ACC provides. Every little small increment in that dotted blue line going up is many, many millions of dollars. You can see in the middle period there's a flattening of the line. You might think about why that would be. Why would there be a flattening in that time period? Anybody want to shout out? What was happening in that time period in New Zealand? No, this is treatment injuries, nothing to do with sensitive claims. But it's across ACC, by the way. You see the same issue of a flattening of claims in that period. I think it's the global financial crisis, which all insurance companies see that, and all compensation schemes around the world see the same thing. When you have an economic crisis, people are more thinking about their personal situation and maintaining their work rather than making a claim. So in some ways, the rise after that period suggests an improving economy? Or does it suggest worse care in hospitals? No. Doesn't suggest any of those things, does it? It's something about more claims are being lodged. We don't know all the reasons why. We do know some of the reasons why. The other thing to look at here is we account money in different ways in ACC. We account the money for each individual claim. We account the money for serious injuries. That's people who are going to have a lifetime relationship with ACC because their injuries are particularly severe. And we have to put money in the bank. We're required by our Act to be fully funded. That is to have money in the bank to look after all those people that are on our books and the lifetime of their expected injuries. So our actuaries account that every year and update the costs and tell us how much money to have in the bank. For treatment injury, that's currently $5.7 billion that we need to have. For ACC as a whole, we have over $40 billion in the bank on behalf of you levy payers and taxpayers to look after people who are currently injured. The difference for treatment injury is the levies that come for the account don't come from like your vehicle registration or out of your pay packet or your boss's costs. It comes from the taxpayers. There are no levies applied to treatment injury currently. The rising costs worry us in ACC, not because it's money, but because behind the money, those are injured people. If, for example, it's a baby with neonatal encephalopathy, it was injured in the birthing process due to the actions of the health professionals, and that baby's with us for their life, that's about $30 to $50 million. Gosh, that... Yes? A tiny bit. No, they go into the workplace account, for example, for workplace injuries, and your levies that come out of your pay packet go to non-work injuries. So the Act specifies where we have to spend the money and who we get it from. We published, and I think you've got on your desk some of this information, yes? Have you got one there? So we published this in April this year, looking at information on treatment injuries across DHBs and some information about all of New Zealand, not just DHBs. We'll be publishing an update of this that includes Private Surgical Hospitals Association members later this month. And then again next year we'll be adding in something around primary care, and we'll continue to update it. You can see that claims arising from treatment in public hospitals are the biggest part of treatment injury and the biggest part of the costs. So it costs us in that year $123 million just for that year's costs of accepted treatment injuries. We're doing a lot of things in the treatment safety team to try and reduce the incidence and reduce the severity of treatment injuries, and always keeping in mind that our targets will be, because we look at the numbers, including the costs, and try and identify priorities, either high volume or high cost areas, and sometimes small areas that are amenable to change. So that's the data publication. Just a quick overview of some of the initiatives that we're doing. One that I think Dee should put up a hand and wave at you about is the anticonvulsants during pregnancy. It was a great little project that Dee worked with consumers and various other people on, MedSafe, a whole range of people, to produce more data and helpful information and pamphlets so that women of childbearing age either don't take anticonvulsants or have an informed discussion with healthcare professionals about whether they should continue to take anticonvulsants in that period of their lives. Why? because the baby can be injured. A lot of you are pharmacists, you understand that. The baby can be injured in utero by taking the anticonvulsants, and they may be, therefore, one of our clients. Another one that's interesting is pressure injuries, not a big cost in treatment injury. But not a big cost because most of these people are not wage earners. So they won't be getting earnings-related compensation. They'll be older people and they'll require a lot of treatment and home support, which are less costly than wages. So we looked at that, and we also are worried about the impact of a pressure injury on the person and their family, which can be quite horrendous. Once again, we've been working with other agencies, the HQSC, Ministry of Health, to produce guidelines on avoiding pressure injuries, which is an interesting point. Most of the claims, almost all the claims we accept for pressure injury in treatment injury are because either the person went to hospital and had no assessment done of their risk of getting a pressure injury, so failure to assess, or they had the assessment done and nobody put into place the actions to prevent it, so failure to provide treatment. And we'll come to professional accountability at the end to talk about that. You're more interested in medications, so yes, we do cover medication problems, including errors and adverse events. Adverse events, the things that come to mind are no surprise to you. It's things like antibiotics and medications for pain. Reactions to injections make up a big chunk of this category, adverse events. And the errors are problems with either prescribing or dispensing. This is data from the publication there on the table. So this is all DHBs, looking at 5 years, and you can see an upswing in claims lodged and the costs associated with that. And then, again, medication errors, all DHBs. It's not a large number of claims. That's good. On the other hand, if we looked at outside hospital medication errors, we'd see a much bigger number. It's an interesting area for me because these claims are very visible. It's easy to make a decision on a medication error claim. Somebody puts their hand up and go, I gave the wrong medication or I prescribed the wrong thing. That's much easier for us to make a decision on than trying to assess whether, like Michael does, was this medication responsible for this constellation of signs and symptoms. Over the last 5 years, looking at medication errors, again, the usual suspects in terms of medications, it's anticoagulants, it's antibiotics, and it's steroids. Doesn't surprise you. And again, medication errors over a 5-year period, the type of injury caused by those things, again, this won't surprise you. It is allergic reactions, although that's a little bit, allergic reaction accepted as an error. In other words, somebody was given a medication that they were already allergic to and we knew it. Cerebral hemorrhages and cerebrovascular accidents, that'll be related probably to anticoagulants. Yeah, so this is errors, not adverse events. So you can have a claim made because you had the medication causing a physical injury, aside from error. In other cases, the basis of the claim is somebody made a mistake, an error. Thinking about that a little bit more, if there is a failure, an error, then all the exclusions won't apply. You can't have an ordinary consequence of bad treatment. That doesn't make sense, does it? But you can have an ordinary consequence from good treatment. So thinking about that a bit further, what's the likelihood of a child getting diarrhea after Augmentin? Pretty good. So that's probably an ordinary consequence. But giving you Augmentin when you're allergic to it, that's not an ordinary consequence, that's an error, yep. Somebody agrees with me. Yes. Yes, so that was here, Michael, another learning today, that was a willfully self-inflicted injury. You will have cover, you will get treatment by ACC and no other entitlements. no compensation for permanent impairment, no new car. Medication adverse reactions, this is over the more than 10 years that treatment injury has been going, and this is just showing you the cost of serious injuries. Now, serious injury is our classification, not yours. It's people that are going to have a lifetime with us. So you can see a very, very small number account for a very, very large cost. Why? Because they're with us for a long time, a lot of wage compensation and other supports. Oh, we talked about fetal anticonvulsant syndrome. Big ups again. This is what I really like. It includes this type of helpful information where you and I understand information better when it comes with both a narrative and some pictures. I think the app and the wrap are still coming. Is that right, Dee? A wrap, something like that. I want to talk about professional accountability because under Section 284 of our legislation, all claims that are made for treatment injury are assessed for risk of harm to the public and all similar claims. So the osteopath claims that are not under treatment injury but are similar will also be considered. If we assess the claim and believe there's a risk of harm to the public from that event, that injury, we're obligated to report that to the authority responsible. The authority responsible might be the National Radiation Laboratory, it might be MedSafe, it might be the Director General of Health, it might be your registration authority. It'll depend on the circumstances. It's about 4% of all claims are sent for risk of harm notification. We have used, since our inception, the HQSC's Serious and Sentinel Event Reporting Framework. In assessing those claims, HQSC has updated that, so it's time for us to update our risk of harm notification policy to make sure it's usable and it helps people improve. We don't litigate anything, but we investigate claims. That's kind of a distinction in my mind because that's what our Act says. But your base question, if there is an HDC report available, that's important information for us. We sometimes will ask the claimant to await the outcome of an HDC report. If they don't want to, we'll make a decision irrespective of that because our Act tells us we have to make decisions in a timely way. We have very strict timeframes. If we get new information later that either says we should accept or we should decline based on the new information, we'll consider that carefully. There are court cases around what type of information we can consider once a claim is made. Our goal is not to prejudice the customer, the client. Well, that's the point why we would ask, can we delay while that's going on? Particularly when it's around an allegation of failure. You know, there's more than one person involved now. There's the health professional. So natural justice, yeah. In the last financial year to the end of June 2016, there you go, 509 reports made that were serious and 78 reports involving sentinel events. And as I pointed out, we want to update that policy. We'll probably be coming to talk to your registration authority about how we can make this much more helpful. Any questions? Oh, did we get back to that question? You guys been thinking about, does the lady with deep heat get cover? Michael wants yes. I'm going to tell you it's no. There was no treatment provided, no treatment, and the application of deep heat by a person for more than a month means she can't have cover under the ordinary provisions either. More than 1 month application of a substance to the skin. Gosh, that's really tricky, isn't it? Other questions about treatment injury? Yeah, that's a very good question. So it's around if somebody's taking warfarin and they get a cerebral hemorrhage, obviously it's the warfarin that's caused the cerebral hemorrhage, plus or minus the salicylates or something else, is that ordinary? In my thinking, no. Those occur in about what percentage of cases, Michael and Michael? 10%. So 1 in 10, that's probably on the borderline, somewhere around what might be considered ordinary. So we would look at the particular circumstances of that person. Was it that they've been taking too much, or they were prescribed too much, the INR was really high, or was they had a very stable INR pattern and this was an out-of-the-blue hemorrhage? Those sort of things would help tip it one way or the other. You can have cover from a bee stinging you. That's an external force. It causes a physical injury. If you have an anaphylactic reaction from the injected poison, that would be a consequential injury. Another thing to learn, Michael. Consequential injury from the injected poison. The difficulty we've had, and we've just refreshed our policy on this, working with Allergy New Zealand, is when will ACC pay for an EpiPen? And that troubles everybody. We'll pay for an EpiPen that you have used to respond to an impending anaphylactic reaction. And we've worked with Allergy New Zealand to outline that. You can get the refreshed policy from our website, or you can drop me an email, I'll send it to you. We don't pay for an EpiPen to place in your car and one in your batch on the hope that you won't get a sting, but if you do, you can jab it. Why? Because we only pay entitlements related to an injury, not to the prospect of an injury. And the courts last week released a decision on that very point about metal-on-metal hips. Yeah, where 4 people went to court to say ACC won't pay to replace my hip. I've got one of those bad hip joint things, those metal-on-metal Dupuis hips. The court said, but there's nothing wrong with you. End of question. That's what the court said. You haven't got an injury? Sorry. Not really sorry, they just said you haven't got an injury. Another question. There must be one. One more? Nope. Last chance. Thank you very much. Oh, another question. I am an employee of the government. I will not make a comment on that question. It's the government's role to administer legislation and change it as they see fit, not my role to comment on it. Thank you very much.